Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. So today is the day. Today is the day to launch the first episode of Own Your Heart Health with me, your host, Dr. Regina Druz. And I'm extraordinarily excited just to be able to bring you some of the stuff that I find fascinating and impactful that enables you to take care of your heart health and to change your healthcare trajectory. In this podcast, we will be debunking some of the myths that people hold dear to their heart, pun intended. We'll be challenging some of the established dogmas and clarifying some of the misconceptions and confusing information that potentially jeopardizes how you may be able to take care of your heart health. You will find that some of my guests will be other practitioners, physicians in both cardiology and non-cardiovascular space, and also some of my guests will be patients. And I have to stop here and really say that I am profoundly grateful for so many of my patients who've been with me for a long time and who have enabled me to become better than just a cardiologist trained in elite universities, but to become someone who can deliver on the promise of holistic cardiovascular care. And I'm honored and humbled by the fact that patients place so much trust and value in this type of care. So one of my goals is to really bridge the gap between what I would consider are traditional cardiac services or traditional cardiac thinking, and you push the envelope so that we can start to look at cardiovascular issues in the context of the entire individual life, right? The opportunities that an individual may have to improve their heart health and therefore to improve longevity. And why do I put heart health and longevity in the same sentence? You may potentially be thinking of these as two different things. And let me tell you that they are absolutely not. The aging process, first and foremost, is reflected in our cardiovascular system. Now, we could find many examples where individuals look great and maybe they have done some cosmetic procedures for their skin, or they look great because they have optimal body composition. And yet, when we investigate, when we go a little bit further, we find that they actually have a significant burden of heart disease. And so heart disease, the process of aging of the cardiovascular system, is the primary aging process. And as you know, most likely, no, this is the number one cause of mortality in both developed and actually many developing countries. So, what can we do about it? And are we all just bound to either die from heart disease or die with it, right? And, I always tell my patients that this is sort of a 50-50, right? You either die with heart disease or you die from it. But, we want to live a healthy, optimal life at any age, and we want to protect ourselves against the serious consequences of heart disease, the ones that take away our ability to enjoy the activities that we like, to be with our family, to travel, and to really be healthy, right? And so what I would think here is what we need to think about is that what are the root causes of heart disease, and actually what is heart disease in general. So in this first episode, I'm going to give you a broad understanding of what heart disease actually is, and I'm going to begin a discussion about a very common issue that I see in my practice, and actually a lot of cardiologists see it in their practice. And I'm going to give you some perspectives on how one potentially could address this issue. So, when we speak about heart disease, for many patients, they traditionally think of something such as a heart attack, for example, right? Or someone who had bypass surgery or potentially a stent. And that's not necessarily wrong, but that's not really a full definition of what is meant by heart disease. Because heart disease comes in many varieties. Heart disease could be affecting coronary arteries. And this is a situation that typically is encountered when somebody is having a heart attack or at risk of having a heart attack or had stents or had bypass surgeries. So this is a very common form of heart disease, and we call it coronary artery disease, or CAD. And you're going to see this probably in a lot of places on the internet and even in scientific publications. Now, there is a different type of heart disease called structural heart disease. And that type of heart disease, unfortunately, is rising very rapidly in the United States. And it has to do with the weakness or inefficiency of the heart muscle. And typically, the clinical syndrome is known as heart failure. And we'll talk about heart failure and what it means, and what it means from the integrative or holistic medicine perspective to actually look at the root causes of heart failure and understand what potentially could be done in addition to medications and devices to improve the opportunities for optimization for heart failure patients. So we have our coronary heart disease, we have our structural heart diseases such as heart failure. A big part of structural heart diseases also has to do with diseases of the heart valves. Now, this is a little bit less common than coronary artery disease, for example, but no less significant. And as patients and we as adults continue to live longer into our 80s, 90s, and beyond, some of these individuals will actually develop valve disease. Usually it's a disease of the valve called aortic valve or aortic stenosis. And there are currently interesting procedures and non-surgical opportunities that could actually help these patients to live longer, healthier lives, right? So we have our coronary artery disease, we have our structural heart disease, which is typically a heart failure and valvular heart disease. And then we have a type of heart disease that has to do with the electrical phenomena, right? Remember that the heart isn't just a muscle that pumps blood forward and is supplied with blood through the coronary arteries. It also has an electrical system, and that's your heartbeat. And obviously, to get your heartbeat, the heart needs to go through a sequence of very specific electrical phenomena so that the heartbeat actually is produced. Now, sometimes these electrical phenomena go off the rails, and one of the common conditions that typically is observed in middle-aged adults, and it's a very impactful condition because it's associated with increased risk of stroke, is atrial fibrillation. So, as part of this podcast and some of the episodes, we'll talk about the atrial fibrillation, what it is, what are the opportunities for a cure for atrial fibrillation, and what could be done from a holistic perspective for anyone who is at risk to actually reduce their risk of atrial fibrillation and even manage some of the risk factors that we know are associated with this particular phenomenon. But today I'm going to start with the coronary artery disease, probably because it's the one where the most controversy exists even today. And the controversy exists in two very large arenas. Now, let me tell you that when I started my journey into integrative and holistic cardiology, it was about 7 years ago or so, maybe 5 to 7 years, and I was very much at that time a conventional cardiologist. Now I had an interest because as a conventional cardiologist, I worked in a large healthcare system, and I was a part of a group. I was head of the group that was specifically responsible for stress tests. Now, if you had a stress test, you probably know what it is. When a patient comes in, usually we connect them to the electrocardiogram and we put them on a treadmill and they exercise. And when they do exercise, we monitor the heart rate and the blood pressure and the electrocardiogram itself. And this is just a very basic description of stress testing. We will talk about what stress testing actually is and what it shows later on, but that's the gist of it. And for some patients who are not able to exercise, maybe they're older or they have neurological or orthopedic limitations, this stress testing actually could be done with non-exercise mode. But I'm talking specifically about my experiences of seeing patients and supervising patients, both younger and older patients, as they were coming in for us for this procedure, for this stress testing procedure. And I was in a very large healthcare system. And so we did thousands of these procedures. Actually, in my lifetime as a cardiologist, I probably have done over 10,000 stress tests. So it was interesting to me that at a certain point, I started to notice that there were patients who did really well, even though they were older. And then there were patients who were younger and they did really poorly. So there was a group of patients who had good exercise tolerance. They didn't really have much in terms of the abnormal findings, even though they were older, and you would probably expect them to be a little bit less robust. And then there were patients who were younger, and you would expect them to do really well, and yet they weren't. And this has started my pursuit. And, as part of supervising these patients and conducting these tests, I would ask them, well, what do you do? Do you exercise? Do you use a certain diet? Do you take supplements? And I would get all sorts of answers. Somebody exercised, somebody took supplements. Some people were gardening, some people were, running, and, some people were lifting weights. There were all sorts of answers, but eventually I could see a common thread. And a common thread was very specific. It almost didn't matter what the patients were doing. What mattered was consistency. And so these patients were the ones who did well, regardless of the age. They were very consistent in paying attention to lifestyle factors. And it usually included some combination of nutrition, exercise regimens, sometimes supplements, control of stress, attention to their sleep, and so on and so forth. And so it piqued my interest because I could definitely see that it had an impact, right? And it had an impact irrespective of the fact that some of these patients had to take cardiovascular medications. They couldn't really achieve a resolution or stabilization of their chronic conditions without those medications. And yet, despite the medications, despite the procedures, these patients were healthier. And so it started my pursuit, and I went in and started learning on my own about integrative cardiology, holistic cardiology. There was actually a funny story, early on locally when I was just entertaining this type of practice. I happened upon a gathering of natural practitioners. And of course, they asked me a very important question, and that was like a litmus test. And I can tell you that I failed that litmus test right away. So they asked me, do I use statin medications in my practice? And I said, well, for some patients, of course I do. And I could immediately, half of the room already sort of peeled off and went the other way. And I learned that, one needs to know their audience. But I also learned that there is a huge need for an informed opinion when it comes to integrative and holistic cardiology. And while people have strong points of view, and I'm not anti-statin or pro-statin, I'm 100% pro-patient. And this is my goal with this podcast and all of the episodes that you will be listening to, as well as all the guests that you may be interacting with. My goal is to give you the tools and the information that is reliable and has its ground in the scientific foundation, but also infuse it with the experience that I was fortunate to gain from working with so many patients in my practice. And so, as I promised, we're starting with coronary artery disease because this is the topic, and I already mentioned, certain facets of it, where there are a bunch of controversies still going on. And probably one of the most common controversies has to do with the use of the statin medications. And maybe let's expand it, not just statin medications themselves, but also with the role of cholesterol in coronary artery disease. Now, you know that cholesterol has been at the center of cardiovascular risk factor continuum used in all sorts of different risk estimators or equations. And the cholesterol lowering hypothesis has dominated cardiovascular thinking for decades. Now, we do, however, understand that the primary driver of coronary artery disease is actually not the cholesterol, but the injury to the arterial wall and the inflammatory process, the inflammation that starts in the arteries that actually then gets exacerbated with cholesterol coming in, trying to patch or repair the inflamed spot. And so this is how coronary artery plaques start. And again, this is a very simplistic description of it, but for the purposes of our discussion here today, it will suffice. And as part of that package of coronary artery disease and the role of cholesterol and the role of the statin drugs, I want to also start shedding some light on a bit more complex topic. And again, this is a topic over which the cardiologists have not reached a consensus yet, although there are different guidelines and different opinions. And that is the topic of coronary artery calcium scores. So I want to kind of bring both of these together and just to start the discussion and to dispel some of the misconceptions or some of the myth that sometimes individuals have when they first are in a situation where they either receive the coronary artery calcium score and they need to figure out what interventions, if any, they would like to have, or they have received a finding of elevated cholesterol and they're advised to go on a medication, or potentially advised to actually go and get the coronary artery calcium score, right? So these are connected type of entities. And so I want to kind of bring them together and try to bridge the gap and to misspell some of the common misconceptions that arise when patients are presented with this information. So what is the coronary artery calcium score? How does it get measured? And what does it mean to have the coronary artery calcium score? Well, the coronary artery calcium score is exactly what it sounds. The technique is the imaging technique that uses x-rays, very low dose x-rays in something called a CT scan. And there are many people out there who had a CT scan for one reason or the other. And so this technique actually measures the deposits of calcium inside the coronary arteries. Now, most of the time, the deposits of calcium inside the coronary arteries are actually on the inner lining of the artery. We call this inner lining endothelium, and they're part of so-called atherosclerotic plaque, right? And, we can call these things blockages because they're easier to understand. There are things that come up in the arteries that potentially could interfere with the blood flow, although they don't always interfere with the blood flow. Sometimes calcium also deposits kind of in the middle layers of the arteries, but it is a sign. So what is it a sign of? Now, it is a sign of an inflammatory process. And this is very important information. And I'm going to go ahead and I'm going to actually share. And if you are you listening to this in audio mode, you may not be able to um, um, see it, but it's okay because you can go on and you can actually look at us on our YouTube channel, and you will be able to see what I'm seeing. So this is a picture that we have on the Holistic Heart Center's website. It's actually courtesy of Cleveland Clinic, and what I want to emphasize here is that I want to really help you to understand that coronary artery disease, CAD, is a lifelong process. It starts at birth, and we do know that even young individuals, for example, those who perish in a battlefield or as a result of, let's say, an accident, during the autopsies, they do have very early areas of damage in their coronary arteries. Those are called fatty streaks. And so we know that this lifelong process involves damage of this little red line here. This is the endothelium or the inner lining of the arteries. And we can measure the stages of this damage, of this disease, and its repair by using specific blood tests as well as using the tests that allow us to see how much damage has been done. And so you could see here those white little dots, which are supposed to represent calcium. And you also could see here an illustration of what may happen when this inner lining of the blood vessel, the coronary artery itself, actually pops open or is damaged and the clot is formed. And this is what typically results in unstable angina or a heart attack, right? Now, it doesn't take very sharp eye to notice that most of these buildups are actually very cholesterol rich, right? And you see all these, yellow area here in this diagram. This is where cholesterol actually is. And while cholesterol is coming in to repair the damage in the artery, it eventually becomes a promulgator of further damage because as this gets stuck in the plaque, it further gets involved in inflammatory reactions, and this is so-called plaque remodeling. And this remodeling is active inflammatory process. So how does calcium actually fit into it? Well, calcium is the end stage of the inflammation that happens in the coronary arteries. So what that means is that once this process is ongoing, and you could see it here, doesn't always result in this rupture or erosion and a bad event, such as a heart attack or a stroke, for example. Over time, some of these plaques become sealed with calcium. So the way to think of it is if you, for example, recall if when you were younger, perhaps maybe you fell and, scraped your knee, or maybe you cut yourself somehow, right? You had a skin scrape of some sorts. And initially it's red and, raised and bumpy. But as time goes on, a scar is formed. So it may not truly ever go away if it's deep enough. So there's always going to be a tiny scar, but that tiny scar doesn't bleed. It's not red. It's not hot. It's not inflamed anymore. It's sort of a done deal. So this is exactly what the calcium represents in the coronary arteries. It's a done deal. It means it's the inflammation that in a particular spot has run its course. And as a result, since it had run its course, it had essentially made this particular area, by calcifying it, it made it stable, right? And we do want this stability because we know that the plaques which are stable, which are calcified, they don't do this, right? They don't rupture and they don't erode. They don't, start this cascade where a blood clot could form inside the artery to give somebody a heart attack, and if it does it in the brain, a stroke. So what is the role then of cholesterol in it? And, I'm going to bring up an interesting resource, and this resource is free. It's for patients. It's called knowyourrisk.com, and it's actually provided by Cleveland Heart Labs. And I want to bring it up because it is important to understand the process. Right now, I don't quite agree with the way the information is presented here because it continues to be very cholesterol centric, stating that it's the cholesterol that injures the wall of the blood vessels, right? Well, while cholesterol does injure the wall of the blood vessels, the initial surge of cholesterol is with an intention to repair, because all of the cells in our body produce cholesterol. We need it to survive. We need it to maintain our cellular integrity. And so this repair process is central to us being able to maintain our tissues. And we know, for example, that it's really the lifestyle factors, the unhealthy diet, smoking, diabetes, high blood pressure, poor lifestyle habits, stress lifestyle, and in the integrative land, oxidative stress and hormonal imbalances, as well as environmental influences that are actually playing out on the inner surface of the blood vessels, the endothelial surface, and are causing a lot of these micro damages. And just from the sheer blood flow itself, over time, some micro damage takes place. And we know that, half of the patients who experience a heart attack actually don't have any cholesterol related issues. It's a known statistic in cardiology, and it's sort of like a flip of a coin, but all of the patients who experience heart attack have some type of inflammation, whether it's detectable in the blood vessel wall or potentially it's detectable systemically through some of the things that we can measure in our blood work. So if inflammation is the core driver and cholesterol gets deposited, as you had seen before, into these walls and is building the plaques, right? Building the blockages. And then the calcium is the final stage in this progression. Then can we reverse the calcification? Is it something that is meant to be reversed? And I get this question asked numerous times, right? Can my calcium score be reduced? Or can the calcification in the coronary arteries be reversed? Now, the answer to the second question, whether the calcification in the coronary arteries can be reversed, is a firm no. There are currently no means known to medicine, any type of medicine, that could allow us completely reverse this inflammation process that had reached its final stage, the stage of calcification. However, what we can do is that we can absolutely reverse the root cause drivers of this inflammation process, reduce inflammation itself and the impact that it has on the coronary arteries or vascular system in general, and slow down the damage that is happening as one gets older. And this is where the impact of lifestyle factors is so profound, specifically in arresting or reversing the process that damages the coronary arteries. And we know now that the calcium deposit is the end result of this process. So very often when patients start on the lifestyle modification, and especially patients who actually use some amount of statin medications, which are known to be stabilizers of the vascular lining and promote the healing of the plaques, right? Promote decalcification. Very often in these patients, we actually see an increase in the calcium scores. Now, calcium scores are very tricky because when a calcium score is 0, this is an indication that the end result of inflammation in the blood vessel has not been found, right? And so we know based on the medical literature that patients whose calcium scores are 0 are pretty much in good shape, at least for a while. And we'll talk in later episodes what it means to have a calcium score of 0 and at what point should an individual say, well, it's time for me to repeat it and see if I'm still a 0 or not. But once the score is beyond 0, and there are different score categories, we tend not to repeat the score because for a number of reasons. Number one, we know that once a person is committed to lifestyle modification or using medications or both, the calcium score is likely to increase because the areas in the blood vessels that were inflamed but haven't had a chance to calcify yet will arrive at calcification as inflammation resolves, right? So this is just a function of time as well as a function of the interventions that an individual is taking. We also know that the calcium scoring itself as an imaging technique, and I've been a cardiac imager pretty much since the beginning of my cardiac career, the calcium scoring, even in the modern day scanners, has some variability. So we typically don't repeat the calcium scores because we may find them somewhat higher, we may find them somewhat lower. There will be some variability, and this variability is significant in kind of mild to moderate ranges. So if we can't reverse the calcium score, what can we do? Well, we can certainly work on the root causes, inflammation, oxidative stress, autoimmune response, toxicities, and so on and so forth that are driving the inflammation of the artery. So we could certainly impact the factors that are promoting vascular inflammation, and in doing so, reduce the potential of the coronary arteries to actually continue to grow these plaques, continue to grow the blockages. How should we think about it, right? What should be a way for us to put it all in context? Because one of the things that I find very frustrating is that patients very often get attached to a specific number. Let's say it's a calcium score, or it's the bad cholesterol number, or it's ApoB, and they don't necessarily receive guidance from their physicians on how to think about it altogether within the context of their other risk factors. And it often breaks my heart to see patients go and, into some sort of extreme diets or exercise regimens or use 10,000 supplements to try to normalize a specific parameter and not really realizing that they really have an opportunity somewhere else and maybe even foregoing important treatments instead of the treatments that are not likely to make an impact. So that brings us into the territory of cardiovascular risk prediction. And again, this is a fairly significant area. It's a very diverse area. And there are multiple risk equations that one can use. But I want to start to bring in an equation that I use very often with our patients. And these equations, and again, this is entirely free. It's accessible to anyone. The links for all of these will be in the show notes. So if you're listening to this, please take a look at this podcast episode on YouTube. And also please take a look at the show notes so that you can get access to this information. But the way for you to begin to think about it, if you have a calcium score, is putting it in perspective, right? So we'll work through this together. It will be our thought exercise, and we'll take a situation that I commonly see. It's not a particular patient, but it's sort of a sum equivalent of multiple patients that I had seen. And so I wanted to illustrate for you the calculation of coronary artery age. Now, this calculation is based on a study called MESA, which stands for Multi-Ethnic Study of Atherosclerosis. And that actually was and still is a very pivotal study in cardiology, because that study was focused on individuals who at the time of the study had no issues with their heart, so they had no coronary heart disease. And it focused on enrolling these individuals so that people could be represented based on their gender and based on their race, right? So really to reflect diversity of the population in the United States and give information to people who are not just of particular ethnicity, but to really derive information for multiple ethnicities so that people could understand what their cardiac risk is. And so the MESA risk score and coronary age calculator are very well-known calculators, again, available for free. You could see here that this is actually from National Heart, Lung, and Blood Institute, so NHLBI, and you can actually download it as an app. Right, so I'm going to take a situation, and this is actually a patient who I just saw yesterday. So let's go through this now. You could see that majority of these risk estimators, they are for middle-aged individuals, although 65 to 85 is probably more of a mature adulthood. There is a version of this for younger individuals, but most of the time, the patients that we see, they come to us when they are in the middle ages. So somewhere I'm going to see between the ages of 45 to 65, when we're much more commonly to see these patients. So now that you know that coronary artery calcium score is not reversible, and that you could certainly do things that proactively that could help you to reduce the chances of coronary artery calcification, and that the coronary artery calcification represents the final stage in the process, in this process of inflammation of the coronary arteries. Let's figure out, what does the coronary artery calcification actually mean? So let's assume that we're seeing a patient who is a male, and let's say he is 52 years of age, and he had listened to this podcast or some other podcasts, or have done some internet search, or maybe spoke to a neighbor or a friend, and that person suggested that they should go and get coronary artery calcium scanning, right? Let's say that this patient is Hispanic, and they're not a diabetic, they're not a smoker, but they have one of the uncles on their father's side who had a heart attack when they were 57, right? And that does qualify as family history of a heart attack, right? And so we're going to say that this patient's cholesterol is, it's very common, again, in the middle-aged adults. We're going to give him a total cholesterol of 220. And, a lot of patients who are male patients tend to have lower HDL cholesterols than women. But let's say we're going to give him a fairly decent one of 45. And we're going to say that this patient is otherwise healthy. They actually don't have high blood pressure. So we're going to give them a blood pressure of 118, so less than 120. They're not on any medication for their cholesterol. They're not on any medication on their blood pressure. So now we're going to go ahead and we're going to do something called calculate their 10-year risk of coronary heart disease. Now, that is a risk of coronary heart event, such as a heart attack or cardiac death, right? So these have been observed in the population. This is what MESA study was all about, to actually track what happens to individuals when they start off as healthy without any evidence of heart disease, and what happens over time. So we're going to go ahead and calculate this individual risk. And we see something very, very interesting, right? Now, remember that this individual, our hypothetical patient, is 52. However, if we did not input his coronary artery calcium score because we don't have it yet, he just, let's say he comes to a primary care doctor, and the primary care doctor gets this blood work and the blood pressure measurement, and they just, plugged it in into the calculation. Now we could see here that this person's 10-year risk of coronary heart disease event is at 5%. So 5% per year is so-called intermediate risk group or intermediate zone. But based on these numbers, the assessment is that this individual's coronary age, the age of his coronary arteries, is 59. So this is 7 years older than his chronological age. Now, let's see what happens if this individual actually goes and does coronary artery calcium, and let's say that he gets the best possible result. The score is actually 0. We're going to ahead and calculate his risk, and you could see that immediately he fell from that intermediate risk group to low risk group, and he is actually much younger in terms of his coronary age. He's 46-year-old, right? Now, what if this is not the case? What if, as many middle-aged individuals, there is some amount of calcium already deposited in the coronary arteries? And again, this is very common because we find that small deposits of calcium are fairly common in middle-aged individuals, because remember how I said this is the final step in the resolution of the inflammation that had taken place in the coronary arteries. And so we're going to give him a fairly low coronary artery calcium score, and the coronary artery calcium gets evaluated in 2 ways. There are categories of risk, which are sort of buckets for everyone, and then there's a category how that your specific number, where does it places you. And so typically the category of risk, which is 0, is considered the lowest risk. Once the individuals have coronary artery calcium scores, which are, let's say, greater than 0, but less than 100, this is somewhat of a higher risk. Between 100 to 400, even higher. Over than 400, the highest, and over is than 1,000 is really, really high, right? And depending on which study you read, you may end up with different numbers. But, the purpose of us today in this first episode is not to look into these numbers, because we will be looking at them down the line and making sure that we understand where these numbers fall. But for today, we simply are doing a simulation to help us understand how to process the coronary calcium score, how to take it in perspective. And we haven't even discussed which patient should go and get coronary artery calcium score, because I have to tell you, there is a lot of disagreement on it among cardiologists. I just literally, before recording this episode, looked at a discussion in American College of Cardiology, and we had a little poll. And, the cardiologists who were polled, they're sort of split, because some people do favor referring to coronary artery calcium for individuals who are younger, who we know typically are at the lower risk, 10-year risk, because they're still a little bit too young. Other people feel more strongly about referring individuals who have somewhat higher risk, maybe not low, but intermediate risk, or are older. And there are certainly cardiologists who don't feel that coronary artery calcium score is useful. But for our purposes here, and we use a lot of coronary artery calcium scores and additional cardiac evaluations at the holistic heart centers, for our purposes here, we're going to say that this person's coronary artery calcium score is 119. And I'm just picking a number out of the hat, sort of not particularly low, but not particularly high. I'm going to go ahead and calculate this person 10-year risk. So here's what is happening, right? We see now what actually happened to this individual. Let's focus on these kind of 2 outputs of this model, right? When we didn't have coronary artery calcium score, because of the family history and because of some of the elevations in his lipids, his 10-year risk of coronary heart disease event, a heart attack, or a cardiac death was low to intermediate, and his coronary age was judged as 59 because the numbers that he had in terms of the cholesterol and the blood pressure were more consistent with an older person. Now, you remember that when we did a demonstration earlier on, when we put a coronary calcium score of 0, we actually ended up in a much better situation for this individual because his 10-year risk dropped by about 50%. But when the coronary calcium score is 119, his 10-year risk is actually now much higher. And so high enough for us to consider pharmacological treatment and have a discussion with this patient. And of course, as well as lifestyle modification. And importantly, we could, based on the information from the MESA study, we know that this calcium score of 119 on average is what we see in a 75-year-old man who is Hispanic, but not in a man who is 52. So I hope this demonstration was interesting to you, and it was an illustration of how you can begin to think about coronary artery calcification and what it means. So let's sum up some of these musings, if you will, and give you some actionable information, something that you can hopefully use to understand what discussion you should have with your doctor, and should you run and get a coronary artery calcium score or not. So before you do decide to go and get the coronary artery calcium score, I definitely suggest that you at least plug in whichever numbers you have into the MESA calculator. Now you had seen it now, so you know these are not very difficult numbers to get. And chances are that at your last physical, you had some information with regard to your total cholesterol, HDL cholesterol, as well as your blood pressure. And you do know your family history, and you do know whether or not you're on any medications and so on and so forth. And that's going to give you a context for a discussion that you may wish to have with your doctor, right? And within that context, of course, there could be other different clinical circumstances. You know, I'm just in this initial episode beginning to scratch the surface, but there could be other considerations. But for now, we're just going to stick with that MESA calculator. So once you have that understanding where you may fall, depending on the things that we know now, this is an opportunity for you to discuss it with your healthcare practitioner. Will you benefit from coronary artery calcium scoring or potentially some other cardiac testing? But today, obviously, we're focused on figuring out your cardiac risk and what one needs to do about it, right? So before you run out to get a coronary artery calcium score, do look at the MESA equation, do your due diligence, bring this information to your healthcare practitioner so you can have an informed discussion whether or not the calcium score is indicated. Now, some practitioners feel that if a patient is not likely to accept medical treatment, for example, patient says, I absolutely will not be on a statin medication, no matter what that calcium score is, some practitioners may say, hey, then maybe you shouldn't be getting it. I happen to think that more information is better. The calcium score is a fairly easy test to get. It's a very low radiation exposure. It is commonly available, usually in large metropolitan areas and even in smaller towns. And the cost for a calcium score is variable, but at most it costs maybe $300. And in some locations, it's much less than that. And actually, I have a colleague in Fargo, North Dakota, and his group gives it out for free. They call it HeartScan, right? And so they really hope that patients take advantage of the opportunity to begin investigating if they need more intensive treatment for something that could down the line depending and develop into a significant health issue. And so do get do ask your practitioner to run a MESA calculation or run it yourself before you decide whether or not it is worth your time, money, and just effort to actually go and get the calcium score. If you do decide to go get a calcium score and your calcium score is 0, congrats. That's the best possible scenario. And we will discuss in the subsequent episodes what does it mean to have the coronary calcium score of 0? Does it mean that one doesn't have any coronary artery disease? The answer to this, hint, hint, is no. But the chances of having any issues due to coronary artery disease, such as a heart attack or cardiac death, are negligible for someone who has a score of 0. Actually, that you saw in the calculation in the simulation before that the numbers differ, of course, based on the scenario, the age, gender, ethnicity, and other parameters. But across the board, for patients whose coronary calcium scores are 0s, their chance of having any cardiac event in the next year or so is about 1 in 10,000. So this is really great category to be in. If your coronary calcium score is not 0, this is where you definitely need to have a very thorough conversation with your healthcare practitioners as to what is available to you in terms of the options to slow down or reverse the process of atherosclerosis. Now, remember, as I said before, you will not be able to reverse the calcium score. It will not evaporate out of the coronary arteries. It will not disappear. But what you can and should do is to figure out what are the root causes that are driving inflammation in my arteries. How much inflammation do I actually have? And what is it that I can do to reduce inflammation, reduce its impact, and protect myself from possibly the situations where the areas in the arteries which are inflamed could potentially become super inflamed, which is what we had seen in the earlier infographic, and sort of pop open and give you a heart attack or, God forbid, something even worse than that. So this is a very important conversation, and I have conversations like this with my patients on a daily basis in guiding them, trying to figure out what is the best strategy. We actually do use pharmacological treatment as well as holistic treatment, and that's the essence of personalized approach. And we use an approach called ALARA, which takes me back to my days of cardiac imaging, and it stands for as low as reasonably achievable. And it's interesting because European Society of Cardiology that just wrapped up in Paris actually used this concept with regard to kind of giving guidance about patients who may not be tolerating pharmacological regimen to really try to do everything possible to achieve as low as reasonably achievable lipid numbers to really optimize these persons' cardiovascular risk. So I hope this has been useful to you. If you are on the fence about getting coronary artery calcium score, discuss it with your doc. You can always put some comments on social media for us and respond to this episode. I want to hear from you if you agree with me, and I especially would like to hear from you if you don't agree with me. You can absolutely share your story, although, of course, I won't be able to give you medical advice. But, this is a collaborative learning opportunity. We also have a private community called Holistic Heart Universities, and you will hear about Holistic Heart University and how you may potentially get involved in the ed sections of this podcast. And with that, thank you for being here with me for this first episode of Own Your Heart Health, and get ready for a much deeper discussion about the statin medications and the LDL cholesterol. We will, in the next episode, focus on LDL cholesterol. How low should we go? And if low at all, right? So stay tuned, and I will see you soon. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.